Uh, Good evening, Gaetano. Do you hear me?
It's fine.
Okay. I'm very
Thank
glad.
you very much.
I'm very glad to introduce you in the audience, Professor Gaetano Thiene, the leader in the area of arrhythmogenic cardiomyopathy. Unfortunately, he cannot came in Thessaloniki. Is going to present a very, very special issue, bicuspid aortic valve, the most frequent but not so benign congenital heart disease. Is it true that
Yes.
there is...
Can I start?
Okay, you can start.
Thank you very much. You believe me like an eclectic professor because I spoke of history of medicine, valve disease, heart valve, heart muscle disease. I love everything. Anyway, bicuspid aortic valve. Are you aware that it is the most frequent congenital heart disease, apparently benign, but not so benign, that is doubling the number of congenital heart disease in terms of incidence? You know that in the past there was an investigation on bicuspid aortic valve incidence at autopsy, prevalence at autopsy, and you see is varying in between 1.2 to 0.5 to 0.5. And look at here, this is much more reliable because this is an echocardiographic investigation in children, live children. And you see that the prevalence indeed is 0.5 or 0.8. So it's the most frequent heart disease, congenital heart disease. Okay, look at here, this is a drawing from Leonardo da Vinci, depicting indeed the aortic valve, three cusps, and is in comparison with a gate in the river. So, but what is the ideal in the mind of Leonardo? Was it the tricuspid valve? Was it the bicuspid valve? Was it the quadricuspid valve? No. He decided that the best indeed is the tricusp valve. Okay, let me cover this aspect this evening. Anatomy and embryology briefly is question. Is valve a genetically determined malformation? What is the natural history, which may be catastrophic? Is it only a problem of cusps or something more in the aorta? Okay, so look at here. We divide in sinuses of Valsalva here, valve leaflet of cusps, commissure, that is here, the higher point of the cusp attaching to the aortic wall here and the aortic wall. Aortic wall is an intrinsic part of the aortic valve apparatus. Look at here, as far as histology, we divide in ventricular layer, elastic. In the media, there is, you see here, spongosa, and facing the aortic wall, there is the fibrosa. Okay, as far as the coronary arteries, they are arising at the level of sinotubular junction here, and we have right or left, and we have a non-coronary cusp, which is here in continuity with the mitral valve. Okay, this is the aortic wall. I want to stress and to draw your attention that the wall is a very, very important component of the aortic valve apparatus. You see here the intima, the media with the elastic lamellae here, and within there is smooth muscle cells. Muscle cells are a mesenchyma or a parenchyma. Is the aortic wall an organ? I believe that it is an organ. And you look at here the lamellar unit. We have the smooth muscle cells, which is synthetic because may produce also collagen, may be constricting because it's spasmodic. And you see here in between the elastic lamellae. Okay, we have basically two types of bicuspid aortic valve. We have a type 1, in which there is a fusion of the anterior right and the anterior left coronary aortic cusp, you see here, and here is the raphe. And here is the other one that is the non-coronary. Another possibility is that this is anteroventral, ventrodorsal, sorry, and this is side by side with this fusion, which is the raphe that we now mentioned, raphe, and the fusion is not in between the right anterior and left anterior cusp, is in between the left anterior and the non-coronary. Okay, look at here. This is the bicuspid aortic valve, the classical bicuspid aortic valve. The valve, you see here that we have interleaflet triangles, which are in between the cusps up to the commissure, but we have also this apparent single valve, which is a double valve, because there is a raphe, which is an aborted commissure. And you see embryology. Syrian hamster is the most famous animal with the hereditary bicuspid aortic valve. Look at here. That is, we have in the embryo 4 cushion, and the fusion of these intermediate cushion may lead to 3 cusps in the pulmonary artery, 3 cusps in the aorta. Okay, but maybe a mistake. A mistake is when the cusps the cushion do not divide in 2 components or remain fused because there is a fused commissure. In other words, the bicuspid aortic valve is a congenital heart disease in which there is 2 cushions that instead of developing separate cusps, they fuse and give origin to a single cusp. Okay, look at here. This is a very beautiful. This is normal. Okay, this is a normal development. You see here the commissure. You see here the separate cusp. But here, indeed, there was no division in 2 cusps, and this is a missed commissure because this is the so-called here the commissure fused raphe that is apparent also during living in life in neonate. And this is okay. Look at here. The bicuspid aortic valve is maybe isolated defect, congenital defect, but may be associated with other congenital heart disease. For instance, the ventricular septal defect with aortic arch obstruction present 50%, 51% of the ventricular septal defect with aortic arch problem are associated with bicuspid aortic valve. I want to draw your attention that unbelievable. 100 cases of transposition greater are associated, only 1 is associated with bicuspid aortic valve, which is incidental. That is the same incidence as in the normal heart. Very, very frequent is, and very, very famous in this, is the association of the aortic arch obstruction, this is coarctation of the aorta, and bicuspid aortic valve, which is prone with time with dissection and intimal tear and sudden death because of hemopericardium. Okay, so now, is bicuspid aortic valve a genetic disease? Good question. Look at here, this paper. That is that there is a familiar occurrence of valve in 9%. 9% is much more than 1%. It's not strictly Mendelian, but is a significant incidence of bicuspid with hereditary transmittable congenital heart disease. In other words, the inheritance is consistent with autosomal dominant with the reduced penetrance, and according with these data, echocardiographic family screening is highly recommended because the risk of recurrence with first-degree relatives patient with valve. In other words, this is a familiar disease. So look at here. For instance, this is another study among 300 and more probants and relatives that participated for this investigation. Bicuspid aortic valve was identified in 24% of 74 probants. So this is the data. This disease is may be genetically determined. Natural history. Natural history is a series of complications that are coming out during natural history. Aortic stenosis, infective endocarditis, ascending aorta, that is aortopathy with aortic incompetence, with obviously surgical problems, big problems, aortic dissection, and sudden death. Sudden death is one of the most important occurrences, because of aortic stenosis in our series of juvenile sudden death. So look at here. This is the calcification, dystrophic calcification. Is in some sort is an accelerated phenomenon occurring in patients with bicuspid aortic valve, whether side by side, ventral dorsal, as I mentioned before. Anyway, dystrophic calcification occurs in the natural history of bicuspid aortic valve and the count of aortic stenosis. Look at here, for instance, the aortic stenosis valve count for aortic stenosis in the adult and the elderly with this data, even 46%. In our hands, 34%. So, in other words, is a very important cause of aortic stenosis in adults and in elderly. Okay, what about endocarditis? Yes, indeed. Endocarditis is anymore a complication of rheumatic valve disease. It's usually a complication at the aortic level of bicuspid aortic valve, and this is the case. This is that there are staphylococci, and I want to mention you that as far as our experience with the surgical pathology, that is, valves are removed at the time of surgery because of endocarditis. Well, bicuspid aortic valve ranks first as a substrate prone to endocarditis, and mitral valve prolapse is 18. Today, in our hands, there is the problem of rheumatic heart diseases as a risk factor of endocarditis disappeared. And look at here, Streptococcus viridis, Staphylococcus aureus, and others. Anyway, what is important that there are two diseases today that are prone at risk of endocarditis. First, bicuspid aortic valve. Second, mitral valve prolapse. Finally, that is a big problem. The bicuspid aortic valve is associated with an aortopathy. That is a progressive dilatation of the aorta with the risk at the end also of dissection. Look at here. The patient with bicuspid aortic valve, this is a normal, this is a time of birth, you see. With time, develop aneurysm of the ascending aorta, both the tubular portion and the sinusal portion. And if you make the histology, in this case, you see that there is a disruption of lamellar unit. Something is wrong there. And okay, so we did an investigation, for instance, in people. They were constrict under 20 years of age, 18 to 20, of course. And this is that indeed we found that nearly 50% of these patients with BAP present with annular dilatation, sinus valsalva dilatation, even at the level of the commissure and at the level of ascending aorta. This is already present at the age of 20 in half of patients with bicuspid aortic valve. And this is a substrate. The substrate is indeed the disruption of elastic lamellae. There is the accumulation of ground substance, Erdheim disease, and this is and this is a classical mucoid substance in between the lamellae. And here, with immunohistochemistry, we see that there is a disappearance of smooth muscle cells. Those cells that we said this is not only a mesenchyma, is a parenchyma, is the cell part of the aortic organ. And how to detect the presence of disruption of elastic lamellae? By echo is easy, because there is expansion during the systole and relaxation during diastole. If this phenomenon is missing, it means that there was a loss of elastic lamellae. Okay, moreover, we have also incompetence. Why incompetence? Obviously, if you have dilatation of sinus part of the aorta, you have incompetence, because the swallow cusps do not reach each other. And you see here, indeed, also in our experience, this is our experience, we have the incompetence. Overall, the part of a competence may vary from 20 here to 5 to here %. In other words, in the adult or even in the young, you can have incompetence because simply a problem related to dilatation of the sinus portion of the aorta. And this is the case. You see here, you see that this is bicuspid aortic valve. There is a thickening of the free margin because enlarging that there is the free margin touch each other, and you have a dilatation of the sinus portion of the sinus valve dilated. This accounts for dilatation of the annulus and indeed incompetence. But don't forget that there is a risk of endocarditis, and healed endocarditis may live here and hollow. Yes, and so this is a cause of incompetence of bicuspid aortic valve as well. Okay, finally, we have the problem of dissection. You know that there is a strongly recommendation to operate these patients when they have a dilatation of the aortic annulus of the aorta, sinus aorta, more than 45 millimeters. Okay, this was a case, for instance, that had a mild incompetence. The annulus was not so enlarged. It was 38 only. 38 only. And we have, soon after this echocardiogram, we see intimal tear, explosion of the aorta, and dissection and sudden death. And this is another case that this is really very impressive, because you see here that is a bomb inside the aorta with the histology showing a disappearance of elastic lamellae. This is an intrinsic disease. We don't know exactly what is the mechanism, but anyway, this is a genetically determined disease. So you see, look at here. If the bicuspid aortic occurs 1 out of 100 patients. The occurrence of aortic dissection in people with valve should be 1%. No, is 13%. In our hands, 12%. There is no doubt. There is a precise relationship in between the presence of bicuspid aortic valve and aortopathy. Again, to stress that bicuspid aortic, that aortic valve, the intrinsic part of the aortic arch, is the attachment of the aorta. Finally, I would like just to mention Gunther. Gunther is a very famous pediatric cardiologist, and he believes that the phenomenon dilatation of the aorta is post-stenotic, is a dynamic problem. No, please. Because, and this he said, but if you consider that this disease, aortopathy, is progressive with time, he says, the most important issue is whether we should unnecessarily frighten 1 to 2% of the general population who have valves with the specter of dissection. My view, as pathologists and cardiologists, believe, my experience, that bicuspid aortic valve is a malignant disease. Thank you very much.
Some comments. Κύριος Βάρδας, ο πρόεδρος του δικτύου, μήπως θέλει να κάνει κανένα σχόλιο στον Gaetano Thiene? No, okay.
What is your...
Professor Vardas, ex-president of the European Society of Cardiology, is going to ask something, to make a comment.
Great. So, first, it's a great pleasure to have with us Professor Gaetano. This is my first comment, indeed, as Professor Gaetano is very well-known protagonist in the European pathology, and especially in sudden cardiac death issues. This is my first comment. As I was listening what Professor Gaetano presented, I was pondering if bicuspid aortic valve to some degree is also related to sudden cardiac death or not at all.
Absolutely. We have 5% of sudden death due to bicuspid aortic valve with dissection. So it's a very serious matter. I don't want to appear as a terrorist, but this is, if you have recommend to check up the family members, and if you are closing to the famous 45 millimeter, 45 millimeters of the size, but the size is not enough per se. Is the progression with time that is very dangerous, and you have to use the echocardiography to investigate the relaxation, systodiastolic expansion of the wall. That is a very important message.
Is any difference between genders and race?
Sorry?
Is any difference between genders or races?
No, I don't think that there is a difference of race. I don't think so. We are, you know, the old story of hypertrophic cardiomyopathy. No, that is this is for any country, any race, any.
So black and white and Asians, do they present in the same rate bicuspid valve? Is that true?
I think so, but I don't know whether we have a precise data coming from there, whether from autopsy, whether from echocardiography. Is it feasible there, or is it reliable there?
Okay. And what about gender? Men and women, do they have the same rate in bicuspid valve?
No difference, no difference.
Okay, great. Thank you very much.
Gaetano,
Yes.
if you know, are there candidate genes under investigation in the case of bicuspid aortic valve? Candidate genes responsible for are investigated now?
No, there are genes. I did not mention. Indeed, there are also precise chromosomes in which there is a mistake there. I'm sorry because I was in the hurry and I had not time to cover this aspect. Anyway, that there is now evidence that there are some genes strongly related to the bicuspid aortic valve and aortopathy, because the problem of bicuspid aortic valve, the true problem, apart from the risk of endocarditis, apart from the dystrophic calcification that occurred 10 years before the senile dystrophic calcification. But apart from that, the major problem, the major challenge, the major danger is the aortopathy and the risk of dissection with sudden death.
Okay, Gaetano, thank you. We admire and love you, as you know. To have a nice night. Thank you.
Pity that I am not in Thessaloniki.
Next time, I'm sure next time you will come.
Thank you very much.
Okay.